All right, so just hit 12:15, so we'll go ahead and get going here today. Hi, everybody. Good afternoon. Welcome to our COVID-19 update through Project Echo Nevada. My name is Troy Jorgensen. I'm the program manager for Project Echo. If you don't know about Echo, we are a telehealth program that originated in New Mexico, in Albuquerque at the University of New Mexico. And really our goal is connecting all of the great resources that we have here through the university and in Reno with our community faculty and community partners, and connecting them with all of you practitioners and providers all across the state of Nevada. And really our goal is supporting you in your patient care, giving you a platform to ask questions to multidisciplinary teams of specialists, as well as gain CME or CEU credit through the didactic portions that we hold each time. So session will start off with introductions, then we'll give everybody an opportunity to ask questions or present a case to the team today, and then we'll get into a couple didactic presentations from the panel. So again, Troy Jorgensen, Program Manager for Project Echo Nevada. Dr. Krasner, if you could please introduce yourself. Looks like you're still on mute, Charlie, so *6 on your phone and we'll be able to hear you. No luck still, so you got to hit star and then 6. There we go.
Oh, hi. So I'm Charlie Krasner. I do infectious diseases for the university and at Sierra Nevada VA Hospital. Welcome today.
Thanks, Dr. Krasner. And Kim?
Hi, I'm Kim Jakes. I'm an infectious disease pharmacist for the Reno VA.
Thanks, Kim. Then we'll have our Echo staff introduce themselves. And we've got a pretty big group today, so we won't ask that you introduce yourselves, but if you can actually write in your name, your credential, and location through the chat box if you haven't done so already for our records, that'd be greatly appreciated. So Dr. Levy.
Hi, everybody. Mordechai Levy here. I'm the medical director here at Project Echo Nevada. Happy to see everybody.
Thanks, Dr. Levy. And Sneha.
Hi, everybody. My name is Sneha Sharma. I'm the program coordinator for Project Echo Nevada.
Thanks, Sneha. And we've got a great resource in Terry Henner from the Savit Library joining us today. Terry, if you could introduce yourself, please.
Sure. Hi, everybody. Terry Henner. I'm the head of outreach services for the Savit Medical Library of the medical school.
Thanks, Terry. All right. So as I mentioned, really our goal is supporting you and answering any questions or reviewing any cases that you may have that you want to run by our team of experts. So does anybody have anything that they want to start us off with today? You know, a specific COVID case or any general questions or anything like that that you'd like to ask? Please, if you do, feel free to unmute yourselves with the microphone icon in the lower left corner of that Zoom toolbar, or you can also write in through the chat box. And I know we did have Cheryl Millsap send in a question through our case submission form. Cheryl, I don't know if you're joined. If you are, could you unmute yourself? I don't see Cheryl joining us, so maybe we'll save that question for a little later in the session. So any questions or cases that you want to discuss with the team, please feel free to speak up. All right, that's no problem. We will have time at the end of the session today for some discussion and questions. So we'll get started with the presentation. This is just a couple housekeeping items. This is our disclaimer, just letting you know that we do record all of these sessions, and if you don't want to be on video, let us know and we can edit it. The second slide here is if you do present a patient case, please just don't disclose any protected health information since we're in a group setting. We just want to avoid any potential violations there. So with that, I will turn it over to Dr. Krasner.
Next slide. How do we do that? So I think we have some interesting topics today. I'm going to talk about the Swedish debacle, and then Kim will talk to us about some nasty fraudulent research, and then we'll top it off by the CDC giving us garbage recommendations. And so just a standard week. Let me go back to the, so anyways, this is just I usually give you an update on what's going on in Nevada, and Nevada continues to do a great job. This is the cumulative rate. So basically how many positive cases we've had, which is just hit 9,000 today, divided by the number of people tested. And you want that the World Health Organization, as we said, you want to be testing enough people so that you're not missing many. And basically, if you have more than 10% of your testing is positive, you're probably missing cases. And the last week we've been down to just 3% of people tested are positive, and give us an overall rate of since this started about 5.6%. So we're really just doing a fantastic job. I heard on the radio today that the state is testing 6,000 people a day. They've tested 160,000 already. So they're really picking up most of the cases. So this is very encouraging. Certainly a big change from about a month or two ago. So we're doing very well on testing, thanks to Dr. Pandori and company. And this is, again, one of the things we're looking at, how much hospital beds are being used up. And if you go back again to mid-April, there was almost 700 people in the hospital. And as of today, there was 360 people in the hospital. Some of them with known COVID, others being investigated. So we've had a significant decrease in the number of people in the hospital. And these are patients on ventilators. Remember, there was that big thing, we're going to run out of ventilators a few weeks ago. And so these are people in the ICU, and these are patients on ventilators. So we've had a significant drop from almost about 180 to 200 people in the ICU and in ventilators. We're seeing around 100, 150. So we're making great progress on that too. These are all good signs. And next slide. And this is deaths. Deaths in Nevada. The state goes back, and instead of saying, oh, we had 12 people over the weekend, they actually go on their website and they list the date of death. And so they may be reported here, but so these are actual number of patients dying per day. Again, mid-April, we were around 8, between 6 to 12 a day for a few weeks there. And, you know, all deaths are not good, but we're certainly going down, and we've been averaging probably about 2 to 3 right now. So we've had a significant decrease in the number of deaths being reported. So we're making progress on all things in terms of number of cases, the number of people in the hospital. Again, however, you know, they opened up the state 2 or 3 weeks ago. So we're really going to start seeing if some, you know, the social unrest and some of the people just forgetting about wearing masks and getting into large groups is going to make it. So we should see in the next week or two whether or not some of those changes are actually going to have negative adverse reporting for us. Next slide. And again, I've shown this before. This is the case rates per 100,000 in different counties. Even though Clark County, which is the right here, has by far the most number of cases, it's the small rural communities. Humboldt County had 78 cases. Lander County had 20. So they actually have an increased case per 100,000 than you know, Clark County or even Washoe County. All right, so it really affects everybody, all counties. And this was something I saw in the paper. And what they did was they wanted to see how much the deaths from COVID have contributed to death. So what they did was they looked at causes of death from February 1st to the end of May in 2014 to 2018, and averaged it out over those 4 years. And during those 4 years, during the late winter, early spring, you have about 200,000 deaths from heart disease, 200,000 deaths of cancer. And if you look at we've had these last 4 months, about 100,000. So it's not as much death as heart disease and cancer, but it would be probably the number 3 cause of death across the country, beating out strokes, the flu, HIV. So it is a significant contributor to number of deaths, but it's not number 1. Next, please. All right, so this is really interesting. Herd immunity. Everybody's heard of herd immunity. Herd immunity basically means that if enough people in your community have been vaccinated or immune to the disease, if somebody comes in with the disease, an active case, there may be enough people to block the spread of the virus. So, for example, if you look over here, if you think, for example, measles, this person in orange has an active case, and the green people are people immune. So, if he has an active disease of measles, for example, measles is very contagious, but he has all these people blocking him from spreading the disease because they'll be exposed to it, but they won't catch it. So you may only get one other case when you have herd immunity. And most diseases, the epidemiologists feel you probably need 60 to 80% of people to be immune to really stop the virus from spreading. And so on the other hand, here we have what is going on with the COVID virus. So here's a person who's infected. Only a few people are probably immune because they've been exposed to it. And very rapidly, if you don't put in any kind of interventions, if you don't put, home quarantine, case follow-up, wearing masks, you very quickly can affect most of the population. They think that it's called an R0. COVID is thought to have an R0, which means if one person has a disease and there's no interventions done, they're just walking around, the average person will infect about 3 people. So you can see if one person has COVID, he quickly infects 3, those 3 infect 3 more, you go up to 9, and then you go up to 27. So it's really almost like a logarithmic increase. So we don't have vaccination right now for the COVID. And so what we've been doing is basically, isolating people, masking them, following up on case presentations. But this is what most countries have done. But Sweden took a different approach. They said they didn't want to do this. They didn't want to, quarantine the government, quarantine the businesses and everything else like that. And so their thinking was that why don't we allow healthy people to get infected with the virus, protect older people, and see if we can develop our own herd immunity. And so Sweden took this approach to say, we're not going to do all these radical changes, lock everything down. Let me show you. So next slide. So what they did, the Swedish COVID-19 approach, first they justified, they say, we're not going to do all this lockdown because we don't want to tank our economy, which tanked anyways. Then they say, well, let's continue what we're doing. Let's try to obtain herd immunity. So they did some things which all other countries have done. They advised older people to avoid social contact, same as other countries. They also recommended that people work from home, wash their hands regularly, and avoid non-essential travel, same as other countries. But what they did was different than anyone else. They didn't close their border. They allowed schools with young people to continue to remain open. They left open most businesses, including restaurants and bars. They didn't do contact tracing, and they said it's okay to have groups as long as they weren't more than 50 people. And this is a picture from Stockholm, where you see everybody's out enjoying the sun. And so this is they're the only country that has really taken this try to develop herd immunity. And again, it's almost looks like what's going on now. Pictures in the last week we saw in Missouri and in New Jersey on the boardwalk. People have really now gone to this idea of not using isolation. So how did this all play out for Sweden? Next slide. So this was, basically what we have is a control group. We have the Scandinavian countries. We have Sweden. And then we have their neighbors, Denmark, Norway, Finland, very similar, homogeneous groups of people. And you can see, so these 3 people all did what the US and other countries, they did lockdowns, they shut businesses, they did case control, filing, and wearing masks, etc. So if you look at Denmark, Norway, and Finland, these are their population, about 6 million, 5 million, 5 million. So they had about 16 million people. And as of about 2 weeks ago, these are deaths, so 400, 200, 800. So 16 million people, they had 800 deaths. And about 2 weeks ago, Sweden had a population of 10 million. They had 2,300 deaths, almost 3 times the amount of deaths compared to these other sort of control groups. And then as of Monday, Sweden was up to 4,400 versus 1,100 in these other 3 countries. So even with a larger population, Denmark, Norway, and Finland, was having a quarter of the number of deaths that Sweden was having. So this didn't seem to be working. And why is this not working? Next slide. Because we talked about, to get herd immunity, you need 60 to 80% of the population. So if these are all these dots, are people immune because they've had the disease or have been vaccinated, this is what you need to control a virus. But look at New York City. New York City had, they had killing fields there. Thousands and thousands of people died, and they had 20% immunity. So even with lockdowns and with they still had many people killed. London, if you remember, Boris Johnson said, "Oh, we don't need to do this." They had a massive number of deaths, and again, they had about 70% immunity. And so again, they're taking this herd approach. Didn't work. Madrid, another site of many thousands of people dead, had 11% immune patients. Wuhan, which had the first outbreak, had about 10%, and they again had to do strict lockdown to keep under control. So look at, here's Stockholm doing this herd approach. 3 weeks ago, they only had 7% of those patients had antibodies. This is not going to work. And so, next slide. This is the death rate per million people across the country, across the world. And who's number one in the world? Sweden has more deaths per million people than any other country in the world. Not something you want to be proud of. Brazil, United States are up there. Finland and Norway, their equivalent Scandinavian countries are way down there. They're actually getting control of the disease, and Sweden is going crazy. And so their death rate is number one in the world. So this is telling us that, we need to continue these, social distancing, wearing masks. So, that now that we're sort of relaxing our controls, we don't have enough immunity in this country or anywhere else to not avoid this widespread disease. And so, I think we can continue to open the country, but we have to be observant to using masks, case controls, case contacts, et cetera, to avoid becoming another Sweden. The World Health Organization commented this week that Sweden has made a really, really dangerous calculation. So it just shows that herd immunity is not available yet. It's not going to be available until we get a vaccine to help control this disease. And so we really need to continue strict attention to the social distancing. Anyway, so that was really interesting. So at this point, I'm going to turn it over to Kim, and she's going to give us an interesting talk. Kim?
Thank you. So Dr. Krasner wanted me to go over some of the issues that we've been seeing with the literature, especially in terms of COVID-19. But before I get too far ahead of myself, I wanted to just do a brief history of clinical trials in general, just because I think that actually may play a role in why we're seeing some of the situations right now. So what's interesting is we actually have evidence of literature dating what look like experimentation in clinical trials to pre-biblical times in 500 BC. But in reality, when we talk about the ethical oversight and the regulations of clinical trials, that's really a much more recent idea. And especially, these were, unfortunately, the acts of things that were atrocities in the name of science. So things to consider, like the Nuremberg Code, which came in 1947, was the result of World War II, with the FDA overseeing clinical trials and the use of drugs for human consumption. That really was the result of thalidomide. And those not familiar with thalidomide, it was used off-label for morning sickness in pregnant women. And it led to horrible birth defects, children born without limbs or truncated limbs. There was also the uncovering of the U.S. Public Health Service Tuskegee syphilis trial, and that had went on for about 40 years before the news got hold of it, and led to these huge ethical dilemmas of patients being involved, being told one thing, and actually scientists going around and doing another. And so with that, we have now things like institutional review boards, investigational review boards, or IRBs, which oversee the conduct of clinical trials, and these are typically done at local facilities and sites. The other thing to be aware of is that when we had a global epidemic with HIV and AIDS, brought into question. We didn't really have anything effective at the time that could be of use. And so then we have now compassionate use of drugs, and that was really what pushed it into that era. Next slide, please. So when we talk about clinical trials, I mean, there's really a checks and balances system. Like I mentioned, IRB is ensuring that we're ethically doing things correctly and that we're maintaining the protocol. But we also have peer reviews, which is, scientists that are typically within the same field or discipline of study, ensuring that what we publish, it meets that high clinical standard, it's meaningful, it was conducted appropriately, and that the results published are hopefully unbiased and make sense. And so recently we've been seeing a lot of studies being pushed out regarding COVID-19, touted by the media and other scientists across the globe. And one of the biggest proponents of those have been the medRxiv website. And to be honest, I was not familiar with medRxiv until COVID-19 happened. It's this huge repository of preprint studies that have not undergone peer review. And I think when I checked earlier this week, there was something about nearly 5,000 preprint articles regarding COVID-19 available. And a lot of the initial data that we had out of China came from medRxiv. One of the more famous ones, or I guess now it should be infamous ones, is the Gautret trial. And this was a group of scientists in France that utilized hydroxychloroquine with macrolides for the treatment of COVID-19. The initial view of it was through preprint, and it actually had a very small number of patients included in the clinical trial. It was about 36. It wasn't randomized, controlled, blinded, and the whole 9 yards. And what they actually ended up doing was submitting this to the International Journal of Antimicrobial Agents, so IJAA. And when we talk about things like peer review process, this is on the timeline of months occurring, usually 90 days before they even get to it. This article was submitted and accepted in 24 hours and then published. And it led to a huge uproar from the medical community. One, there was data not released with it, not all of the control group, all of the, if they were negative as part of their control group. And then there were issues with studies being lost, patients being lost to follow up. And as a result, especially when you have a very small N, I believe there were 36 initially, when you lose 6 patients, your N drops significantly and it can skew your data to show outcomes that you want. And so, what ended up happening is that the International Society of Antimicrobial Chemotherapeutic Agents, they actually had to issue a response saying that we actually found that this article or the study conducted by Gautret did not meet their standards. I don't believe it's been officially redacted, but they kind of did a slap on the wrist as a result of what had happened. Next slide. And so, with that being said, okay, so these are not peer reviewed, they're not published in peer reviewed journals, but what about those that are? So we have now 2 articles, and this is I think led to a huge upheaval in the medical community. We have one that was published in the New England Journal of Medicine, and then another that was actually most recently published in Lancet. And the one in Lancet, of course, being the biggest one that has led to, WHO actually temporarily stopping the hydroxychloroquine trials. What happened was this group, Dr. Mehra, who is a cardiologist at Brigham and Women's, teamed up with Dr. Desai, who owns this company called Surgisphere. So I've never heard of Surgisphere before, and based on all of the articles and even their website, what they are is a database. And so they actually access information on patients across the globe, and their original attempt was mostly with surgical data. What they did was they used information on COVID-19 patients in an effort to try to get more numbers. And I think the N in the hydroxychloroquine study was somewhere around 96,000 patients. So this led to significant impact. But what really happened was once it was published, especially the Lancet trial, statistician in Thailand actually got a hold of it, and he raised extreme concerns about the data and the validity of the data presented. Other authors, that were involved have come out and said, this isn't really a big issue, but there has been no independent review of the data submitted and published in Lancet. One of the other things is that some of the data presented for Australia was actually incorrect. And so they had reported higher deaths initially than what was even reported by the country. And it turned out when they went back and looked, they had actually grouped another hospital that was in Asia into Australia's data. When we do big database type research, typically you have IRB approval, and then your local IRB has to approve what you're doing because you're accessing patient data. And what was another huge thing with most of these database trials done by Dr. Mehra was that there was no IRB oversight. And what a lot of hospitals have said were, we never gave that consent to them accessing our databases. So that's really concerning. We have people data mining without even the approval of the sites involved. And so just even, when we talk about data in general and conclusions drawn from these, I always like to, think the supplemental material is important, getting access to the protocols are important. And these individuals are actually saying that, you don't have a right to do that. And I think because the many people in the medical community raised concerns over it, they are finally conducting an independent analysis of the hydroxychloroquine data. And I heard this morning that WHO is resuming the hydroxychloroquine studies. So just to kind of close out, I think of, statistics and even data are like bikinis. What they reveal is suggestive, but what they conceal is vital. So ensuring that we can access that hard data and kind of make our own assumptions. I've seen, authors change their endpoints 4 times, and that's buried in the supplemental material. Their protocol varies from what they actually did and reported. So that was, I think, the biggest thing to kind of bring to light is that, be careful what's out there. Even if it's in a reputed journal, it doesn't necessarily mean it's good data.
Some of the hospitals said it's not, they were claiming some hospitals in Britain had like 700 cases. And even though they had, at that point in time, there'd only been like 50 or 100. So it seemed like they were making up data.
It's possible that they made it up or they were just miscategorizing things, in the VA, we're the largest healthcare system, right, in the US. And so we do significant data mining, and I participate in those national studies. They have your local IRB approved to even accessing your local data. You can't just, no one can just access the central data warehouse for VA. It's like you have to go through several hoops just to get to that part. Then each site participating needs local IRB approval for it, or they have a blanket statement from the IRB authorizing it. And then we validate the data. So I had to manually go into the charts to validate the data that they pulled to ensure that it's correct. And so I think because they're rushing these studies out, there's no one validating. I mean, especially with huge databases, thousands and thousands of data points, you want, I think, an independent group actually looking at it, ensuring you're not skewing it. They didn't control for confounders. I mean, that's big. It really, people were actually stopping hydroxychloroquine as a result of this.
Yeah, I think France outlawed it or something. They said you had to stop the studies.
Right.
It's scary.
Rick just kind of commented saying, yeah, I mean, it's really just the rush nature of studies that's resulting with that false data.
And I agree, when we talk about peer review and even just getting things through publication, that's usually on the timeline of months to almost a year with, HIV and AIDS. That was one of the hindrances people reported, was because people locked their data down because it was in the pre-publication process. And if they released it too soon, they could lose that publication opportunity. medRxiv serves as a way of, it's nice because it's trying to, that collegiate sharing our data and our experiences, but they even have a huge disclaimer when you're on their website, like that none of this has been peer reviewed or validated, and you should not make clinical decisions based off of it. And people unfortunately are, because we really don't have, a benchmark for the standard of care right now for COVID.
It's also with these vaccine studies, these companies are like Marino is saying, oh, we're getting great results, but they're not releasing any of their records. At the same time, their chief executives sold like $100 million worth of stock. So these people are not being altruistic. It's very scary. And even remdesivir, they were saying, oh, it's great, but they didn't have any data. So, we're going by the seat of our pants on a lot of these studies.
Right. Remdesivir was a huge thing, for Fauci to say it was the standard of care. It really, that was a really big leap of faith because no one had actually outside of NIAID had looked at that data. And then when it was actually pulled, I think people had saw that they had actually changed their endpoints several times in the course of the study. So, I mean, that's the thing when we talk about things like secondary outcomes, half the times, actually the studies you're never powered for the secondary outcomes. What you're hoping is to find something in the data to bring food for thought, right? A correlation maybe.
So much, Kim. All right, I think we'll continue with Dr. Krasner's presentation, and then we'll wrap up with some Q&A.
Kim, that was great. That was so interesting, and just you can't trust anything these days. So this came from the World Health Organization, and they did a systematic review of 170 studies looking at 25,000 individuals. And what they wanted to do was see if they can give a number to what role does physical distancing, how far are you away from an infected patient, what kind of face mask you're wearing, and whether eye protection actually gives you increasing protection and how much it does. Because the CDC in this country initially recommended N95 masks for healthcare workers, but then they downgraded them to, they recommended surgical or even cloth masks would be okay if the supply was short. So now we found that most healthcare workers are only using N95s in really high-risk procedures with aerosolization, such as intubations. But is that just being expedient on the CDC's part, or is that actually good advice? Okay, so this was an attempt to look back at 170 studies and see what kind of evidence by using meta-analysis. And that some of the conclusions that came up was, one, distancing does make it in any kind of setting, when the hospital or the community, the absolute risk of infection was about 12.8% at 3 feet. And if you go back to 6 feet, it was about 2.6%. So there was a significant improvement. And it actually went out to 9 feet, went even more. So definitely the 6 feet seems to be the minimum requirement that we should be keeping our distance in terms of social distancing. Then they looked at the question, is there any difference in wearing a mask versus any mask? So if you're not wearing a mask and you're exposed to somebody who's infected, overall there's about a 17.4% chance of infection versus 3.1% wearing any type of mask. And this was particularly a stronger association in the healthcare setting versus the community. So a mask significantly reduced your risk. But then they looked at the different types of masks, the mask versus the respirator, the N95. And what they found out was that the N95s had a significant advantage over the surgical mask, with an odds ratio of 0.04 versus 0.33. So there's a whole, continuum of masks. Masks make a big difference, but particularly in the healthcare setting, the N95 provides significant advantage over the mask. And they also looked at eye protection, glasses, face guard, or goggles. And again, they found a significant advantage to wearing goggles or glasses or a face guard, about 5.5% chance of getting infected versus 16% without an eye protection. And they acknowledge that, wearing an N95 mask is very uncomfortable. It's hard to talk. The patient feels you're more separated from them. And obviously there's an equity issue with resource shortages in certain places. But again, their study would suggest that the N95 is the best protection. So shame on the CDC. And they had an editorial in The Lancet by a physician, and she wrote that guidelines should be based on evidence, not on supplies. It's like telling an army, oh, sorry, we're running out of guns. Just take these bow and arrows and face the enemy. And so I think that's, we're trying to be expedient to CDC and maybe just not get the White House mad at them. But definitely in terms of protection, particularly in the healthcare setting, the N95 mask has about 96% protection. Surgical mask, 67%, and the cloth mask is better than nothing, about 30 to 40%. And glasses obviously add. Okay, so I know we do have N95 shortages. But again, in the ideal world, we'd all be wearing them, even though they're very uncomfortable to wear. And again, we've talked about this before. People need to wear a mask. You're trying to protect other people, and they should be protecting you by wearing the mask. All right.
Excellent. Thanks so much, Dr. Krasner and Kim.
Sure.
Yeah, we're kind of wrapping towards the end of the session, so we'll open it up right now for questions from the group. If you do have something, please feel free to unmute yourselves using that microphone icon on the Zoom toolbar or right in through the chat box. Rick, do you have something?
It's probably an obvious answer, and I appreciate the speaker being so blunt about some of the CDC stuff, but why do you think they initially were discouraging cloth masks as ineffective and then later said, oh, everybody should wear cloth masks?
Well, I think they weren't doing their own investigation. The Chinese were saying that it wasn't person-to-person transmitted, so they just bought that line up front. And so I think that's where that came from. And now, the more we've talked over the last few weeks, it is, it's those big droplets that when people are coughing that transmit it. And so I think that's basically what it came from. I think there was just a lot of, the CDC wasn't doing the work they should have been doing when they were making those statements. I don't think you can trust them anymore. I mean, I don't know what the hell they're doing. They used to be the gold standard. Now they're a joke. I think they don't want to piss off people.
I appreciate your candor.
They were always, what does the CDC say? But, it just, you can't trust them anymore. It's a shame.
Dr. Krasner, Mordechai here.
Yeah.
Who do you look for your guidelines at this point?
For treatment, we go online to the Yale Medical Center and Mass General, and they have some nice guidelines that we follow. I thought maybe next week we could actually sort of update the treatment protocols. What we know about remdesivir, which was described to me as it's a little looper over the head of the second baseman. It's not a home run, and increasing evidence that some of the IL-6 inhibitors may play a role. But I think it's worth, we haven't talked about in a few weeks, what's the treatment approach, when do we start remdesivir, and what drugs and what else we do. But I think, the big universities are the best place to go.
We do have Dr. Marcus Erling joining us. Dr. Erling, do you have any updates about the lab or testing that you'd like to share with us today? Just a second here, we'll need to unmute, yeah. There you go.
Very good. No, we don't have any immediate updates. We're trying to get the COVID antibody seriously calibrated. And as you've seen, there have been dozens and dozens, a little more than 50 companies trying to push a COVID serum antibody, IgG. And now some of those are being withdrawn because of their lack of quality. The one we're setting up has been Abbott. Is Mark Pandorian?
I don't see him joining us today.
If he's not, well, then I check in with him every day to see how they're doing. They're just starting to make sure that's online.
Okay.
That's all I have.
Great. No, thank you, Dr. Erling. Any other comments or questions from the group?
I do have one.
Yeah, go ahead, Dr. Biden.
Yeah, the stats that were the 172 cases or studies that was seen for over 25,000 people, that particular slide. I'm curious about they saw the comparison between mask and no mask, social distancing versus not social distancing. Are they independent metrics, or were there were social distancing plus mask or social distancing without mask? Or was it any specific numbers on that? Or
yeah, so I was wondering about that myself. I mean, how do you differentiate? I mean, how do you take out goggles? I mean, is it people with a mask, plus or minus goggles? So I'm not sure how they did it. I was looking at the data and it got confused to me, but I assume there must be some way of looking at each facet separately from the others.
Okay. Yeah.
Thanks, Dr. Bayan.